Hi, everybody. Welcome to Gran Rounds for 2026 in January. This month we have Dr. Melinda Steimling talking to us about prehab to rehab and breast cancer care. Dr. Steimling is a physical therapist with an expertise in working with individuals during and after cancer diagnosis and treatment. She earned her Doctor of Physical Therapy from Thomas Jefferson University and is a graduate of an ABPTRFE accredited women's health physical therapy residency at Good Shepherd Penn Partners. She is duly board certified as in oncologic physical therapy and women's health physical therapy. She has been a certified lymphedema therapist and has additional certifications through the Lymphology Association of North America. She has worked for St. Luke's outpatient physical therapy departments, and her clinical practice focuses on patient-centered, evidence-based rehabilitation for persons living with cancer, persons living beyond cancer, individuals living with lymphedema, and individuals living with pelvic dysfunction. In addition to clinical practice, she is an instructor for the Norton School of Lymphedema and an adjunct assistant professor in Moravian University's Doctor of Physical Therapy program. She serves as the Director of Membership and Communication for the Lymphatic SIG of the APTA Academy of Oncology and serves as a clinical instructor for many student physical therapists. So as a reminder to everybody, make sure you scan the QR code or sign in using the information on the left-hand side of your screen. And if you miss this first screen, I do have it pasted into the chat as well. At the end of the presentation, make sure you complete the quiz and the course evaluation so that you make sure you get CE or CME credit appropriately. This is our CME credit information and our statement of need. It is for all providers. This is our designation statement, and the planners and presenters have nothing to disclose. And these are the learning objectives, and I will turn this over to Dr. Steimling.
Thanks, Steve. Everyone. So I'll dive right in. 1 in 8 women in the US will be diagnosed with breast cancer in their lifetime. That's 12.5% of American women. And of those diagnosed, only 2.3% will die from breast cancer. And these death rates from breast cancer have dropped significantly in the last 35 years due to improved screening and early detection and improved treatment. For most women with a breast cancer diagnosis, they will receive surgery as their first-line treatment. And that surgery may be a lumpectomy, where breast tissue is remaining, or a mastectomy, where the entire breast is removed. With either surgery, a lymph node dissection occurs too, and this may be a sentinel biopsy, where only 1 to 3 lymph nodes are removed to check for the presence of cancer, or an axillary dissection, where at least 3 lymph nodes are removed, usually 5 to 15 lymph nodes. For women receiving mastectomy, they may undergo a reconstruction surgery either at the same time as their mastectomy or weeks to months after their mastectomy, and there's various types of reconstruction. Women may then undergo radiation treatment after surgery, and we call that an adjuvant therapy. And they may undergo chemotherapy either before surgery, after surgery, or in lieu of surgery. Other treatments for breast cancer include hormone suppression therapy or endocrine therapy, targeted drug therapy, and immunotherapy. There are commonly recognized side effects from breast cancer treatments, and for surgery, women may acutely experience seromas, infections, pain, edema, or fatigue that generally only lasts for days to weeks. However, women may experience more long-lasting symptoms of scar pain and adhesions, weakness, or lymphedema. And it should be noted that there is a significant presence of shoulder dysfunction in survivors of breast cancer after undergoing surgery, and shoulder dysfunction often presents weeks to months after surgery occurs. Radiation also has some commonly recognized side effects. Acutely, there is a skin reaction called radiation dermatitis that usually resolves within a few weeks after radiation is completed. But individuals may experience fatigue or cognitive changes during radiation, and those side effects may last months to years. And it should be noted that after radiation treatment, radiation fibrosis and chronic skin changes and lymphedema may develop as a late onset, months to years after the radiation is completed. Chemotherapy has many acute side effects that often resolve once chemotherapy is completed, and some chronic side effects as well, such as fatigue, neuropathy, muscle weakness, and cognitive impairments. And all of these impairments, particularly the chronic and late effects, have a lasting effect on patient function during treatment and beyond, and a lasting effect on their quality of life. Breast cancer survivors may experience other side effects from medical treatment. They're at a greater risk for anxiety and depressive symptoms. They experience changes in their sleep quality. They may experience changes in their social engagement and resulting social isolation. And they may have impairments to their ability to work and undergo greater rates of occupational disability. More than half of survivors of breast cancer report physical performance limitations, and over 10% of survivors also report problems with mental health. Cancer survivors consistently report that their health and functional status negatively impact their ability to participate in their life roles. Yet, 40% of survivors report that they don't receive rehabilitation care for the physical impairments that they're experiencing. Specific to older adults with breast cancer, only 16% receive and utilize rehab services. So there are a couple common survivorship needs that I want to discuss. And the first one is shoulder dysfunction. I mentioned that it's common. Up to 2/3 of breast cancer survivors experience shoulder dysfunction. And there are some common risk factors for developing shoulder dysfunction after breast cancer care. Namely, if a survivor has pre-existing shoulder impairments or dysfunction at the time of diagnosis and prior to their treatments, then it is probable that they will experience shoulder dysfunction with breast cancer treatment. Undergoing a mastectomy surgery with axillary lymph node dissection increases the rate of shoulder dysfunction, and radiation therapy also contributes to shoulder dysfunction. Most shoulder dysfunctions diagnosed about 9 months post-operatively, which is why we call it a late effect of surgery or radiation. And there's lots of different types of shoulder dysfunctions seen in breast cancer survivors. Symptoms of shoulder dysfunction in breast cancer survivors are stiffness, pain, and changes in arm and hand sensations. And impairments seen on physical exam include decreased range of motion, particularly of shoulder flexion and abduction, decreased or the painful experience with reaching behind your back to tuck in your shirt, which is internal rotation and shoulder extension, and restrictions to the median nerve mobility, decreased grip strength, and generalized upper quarter weakness of that side. Lymphedema is another common survivorship issue for women with a diagnosis of breast cancer. 1 in 6 women will develop arm lymphedema after breast cancer treatments. And lymphedema of the breast also exists as a result of breast cancer treatments. And while one study publishes a 13% incidence rate, clinically speaking, we recognize that breast lymphedema is often undiagnosed. Almost 2/3 of individuals who develop lymphedema do so within the first 12 months after cancer treatment. And in the chart on the right, you can see the incidence of lymphedema based on the type of breast cancer treatments that women receive, with most lymphedema happening for those that receive both lymph node dissection and radiation therapy. The incidence of lymphedema is secondly caused by just lymph node dissection alone, and third by just radiation alone. But the bar on the far right with a 2.7% incidence is for those survivors that have not received radiation or lymph node dissection. meaning there are other contributing factors to the development of lymphedema in breast cancer survivors. Lymphedema has a significant negative impact on a survivor. About half of survivors experience a cellulitic infection as a result of their lymphedema, and cellulitis can require hospitalization for antibiotic treatment. About 2/3 of women experience modification in their work capacity and reduced work hours as a result of their lymphedema in their arm. And lymphedema, as I mentioned, is associated with declines in shoulder mobility, strength, and function. So addressing lymphedema is really imperative in our survivors. For most women with lymphedema, they are the first ones to recognize their symptoms rather than a healthcare provider recognizing their symptoms. And for about 1/3 of survivors, it takes about 3 months or more to receive a diagnosis of lymphedema after they first recognize their symptoms. So there is a delay in diagnosis and therefore a delay in care. And part of the reason for this delay is because we are able to quantify as a specialty that there is not routine screening for lymphedema, and there's not routine examination once symptoms are presenting and reported. Up to 90% are not screened with an early detection method for lymphedema in their cancer centers. Exercise is shown to be beneficial for cancer survivors. A higher lifetime exercise rate and higher exercise rate before diagnosis and at the time of breast cancer diagnosis has been shown to reduce breast cancer death rate, reduce breast cancer recurrence rate, reduce the side effects of breast cancer treatments, and other comorbidities. However, less than 15% of breast cancer survivors report meeting the ACSM guidelines for exercise, which is 150 minutes of moderate intensity exercise per week or 75 minutes of vigorous exercise per week. So while exercise is hugely beneficial to the treatment process for their breast cancer disease and to life after breast cancer treatment, most survivors are not exercising enough. Exercise before surgery can maximize a woman's strength and hasten their return to function postoperatively. Exercise during adjuvant chemotherapy or radiation prevents decline in function during these treatments and results in fewer and less severe side effects from chemotherapy and radiation. And once their cancer journey is complete, a woman who exercises post-treatment has a better prognosis for recovery of function, resolution of any treatment-related side effects. Specifically, exercise can reduce the risk of developing lymphedema after breast cancer treatment, or at least minimize the progression of lymphedema in a breast cancer survivor. It is recommended that women undergo exercise under the supervision of a trained exercise specialist, such as a rehab oncology physical therapist or occupational therapist, or an oncology trained clinical exercise physiologist, especially early in the treatment journey when there's a lot of medical acuity and a lot of change to their functional status. It's recommended that exercise is prescribed progressively to maximize the benefits and minimize any adverse events. It's recommended that exercise is individualized to accommodate each woman's function and symptoms, and that's best done with a specialist. There are specific exercise guidelines for specific side effects of cancer and cancer treatments, as outlined by an ACSM roundtable published in 2019. And so these guidelines can be selected based on individual needs by these trained exercise specialists. So in summary, there are known musculoskeletal and lymphatic impairments resulting from cancer treatments. Exercise participation, unfortunately, is low in breast cancer survivors. And there is a known positive impact of rehabilitation services on physical function in survivors, yet it is underutilized. So the prospective surveillance model was first published in 2012 by Nicole Stout, and she described it as a model that provides rehabilitation services in a way that prevents and proactively manages these anticipated short and long-term functional changes related to cancer and cancer treatments. The prospective surveillance model includes baseline testing and ongoing screening and assessment with timely interventions if impairments arise or changes in function occur. And the prospective surveillance model includes a lot of education. The frequency of visits within the prospective surveillance model starts high at the early phases of a survivor's journey through cancer treatment, and those frequency of physical therapy visits decreases over time as the individual's medical acuity decreases, as their change in function improves but slows, and as they gain more independence in exercise. The goals of the prospective surveillance model are to promote surveillance and routine screening for the common physical impairments and functional limitations caused by breast cancer treatments, to provide education to the patient and other providers to facilitate that early identification of common impairments, to introduce rehab services and exercise interventions as a first-line treatment for the physical impairments when they are identified, and to promote and support physical activity and exercise throughout the trajectory of disease treatment from diagnosis through to survivorship for women with breast cancer. So this is a schematic of the prospective surveillance model published by Nicole Stout in 2012. And it recommends a preoperative rehabilitation evaluation, followed by an early postoperative reassessment and ongoing routinely scheduled interval reevaluations. The yellow boxes outline the examination and the screening for common impairments. And the green boxes outline the exercise recommendations, interventions, and healthy lifestyle promotion that rehabilitation specialists should be providing through these routine reevaluations. If no impairments are detected, these reassessments should be happening at an interval of 3 to 6 months. But if impairments are detected with the assessment, then skilled rehabilitation programs are initiated, and at discharge, interval surveillance continues. So the prospective surveillance model starts with a prehabilitation appointment. And that appointment includes education, evaluation, and exercise. So let's go through what that looks like. The baseline functional evaluation in this preoperative prehabilitation appointment includes measuring shoulder and spine range of motion, measuring upper quarter muscle strength, measuring arm volumes for lymphedema surveillance postoperatively, measuring gait speed and quality and walking endurance for function, various balance testing, and really determining the individual's level of physical activity, and that includes their exercise status and habits, their occupational status and needs, any hobbies and roles and responsibilities that really impact function for that individual and define them as a person. And finally, we can measure baseline function through questionnaires such as the Quick Dash or the lower extremity functional scale. And all of these are done in that prehab evaluation. Then, in that prehab appointment, exercise prescription is given. And preoperatively, we recommend what the ACSM recommends of 150 minutes moderate intensity or 75 minutes vigorous intensity aerobic and resistance training. We discuss with the survivor how and when to seek exercise with a trained personnel postoperatively, particularly. And this chart below gives a nice guideline for patients, providers, and other stakeholders. And it comes from the National Comprehensive Cancer Network's survivorship guidelines. Prehab appointment also includes a lot of education. We educate survivors on how to recognize and screen for common side effects and comorbidities of cancer treatment. We provide risk reduction practices such as sleep hygiene, nutrition and exercise practices, and fall risk reduction. We provide education on the postoperative recovery and rehabilitation process. And we discuss the role of rehab services and other support services throughout the continuum of their cancer treatment journey. And we find that this education really opens the door for patients, and they see the value in the skilled rehabilitation services, and they see the value in interval surveillance as a result of this education. Prehab also includes a lot of education on lymphedema. We talk about lymphatic anatomy and function, and we talk to a survivor about their individualized risk assessment based on the planned treatments, whether or not they're having an axillary lymph node dissection versus a sentinel lymph node biopsy affects their risk, whether or not they're having radiation treatment or not affects their risk. We provide risk reduction practices to improve their prognosis of lymphedema symptoms, as outlined by the National Lymphedema Network. And we help the patient practice how to screen for lymphedema. Postoperatively, the prospective surveillance model recommends interval visits that include ongoing baseline testing and retesting of everything I just outlined. It includes ongoing education of recovery of function, recovery of their roles, return to work, as well as exercise and lymphedema education. Lymphedema surveillance occurs during the prospective surveillance model postoperative period, and I'll talk about that more in a moment. And those interval visits allow for an opportunity to initiate rehab services very quickly after onset of any new impairments. But ultimately, the prospective surveillance model is geared towards training patients on how to engage in unsupervised exercise to promote long-term wellness practices for breast cancer recurrence risk reduction, as well as general healthy living. So lymphedema surveillance is a crucial component of the prospective surveillance model for breast cancer care. And that's because lymphedema is permanent and progressive if it is untreated. But when lymphedema presents, it can be reversible in its very, very early stages. And certainly the chronic severe lymphedema can be prevented with early detection and treatment. Statistically, we see that with some publications listed here. And in particular, women with breast cancer-related lymphedema who undergo a prospective surveillance model of care have a much lower incidence of that lymphedema progressing to a chronic state versus those that receive rehabilitation referrals after their diagnosis. Because I'll remind you that diagnosis for lymphedema can occur up to 3 months after symptom onset. So that disease has already progressed significantly in those 3 months before they're even referred for treatment, and further delay may happen before treatment begins. So lymphedema surveillance includes the important component of patients recognizing their symptoms. And oftentimes symptoms are a change in arm size, but even before then, a sensation of heaviness in the arm or changes in sensation of the arm, such as numbness or tingling or pressure. Surveillance also includes baseline measurements by a certified lymphedema therapist. And these measurements can use bioimpedance spectroscopy technology to measure extracellular fluid level in an arm, or girth measurements with a tape measure to calculate volumes of arms that can be compared over time. Post-op, it requires a preoperative baseline assessment of lymphedema so that we can gather those baseline volumes so that then over time we can compare them, and if there's change, we can measure that change. The regular post-op screening is really important in the first 12 months post-operatively, and so it's recommended that women undergo surveillance at least 3 times in that first year. And the reason for that is that's when the highest incidence rates for breast cancer-related lymphedema occur. Then the incidence for breast cancer-related lymphedema drops off significantly about 2 years post-operatively, so surveillance should occur for up to 2 years post-operatively. We have thresholds to trigger intervention, thresholds for diagnosis of lymphedema for bioimpedance spectroscopy and for arm volumetrics. And when an individual is undergoing surveillance with a certified lymphedema therapist, those therapists are using these thresholds to determine if treatment is recommended. And if there is a different provider that is performing the lymphedema surveillance, it's imperative that a patient has access to a certified lymphedema therapist in a timely manner at the time of diagnosis. And hopefully that diagnosis is happening within weeks of symptom onset. Lymphedema therapy involves the prescription and fitting of medical grade compression garments, exercise with compression garments in place. And then after about 6 months of wearing compression garments, ongoing reassessment allows for lymphedema therapists and the patient to decide if those garments are working, if they can wean off of those garments with symptom improvement, or if treatment needs to be escalated to more costly complete decongestive therapy because the lymphedema is worsening despite the use of compression garments. And so this decision-making tree really relies on ongoing reassessment to determine the long-term plan for that patient's lymphedema management. It has been questioned whether the prospective surveillance model is cost-effective. And Stout et al. Also published in 2012 some quantifiable costs to the prospective surveillance model as compared to the traditional model of care as it relates to breast cancer-related lymphedema, not necessarily shoulder dysfunction, but lymphedema. And there was about a $2,500 cost savings to the prospective surveillance model compared to the traditional model. And the reason for this is that the cost of the compression supplies is much less for mild forms of lymphedema versus more severe forms of lymphedema. And the cost of the therapy services for surveillance was much less than the cost of 3 times a week appointments for complete decongestive therapy for treating and reversing more chronic or severe lymphedema. So common barriers to the implementation of the prospective surveillance model and the prehabilitation appointment that's included in that include a simple lack of awareness of these services among other cancer center professionals and support staff. Surgeons and other cancer medical staff hopefully will see the value in the prospective surveillance model as a result of this presentation as being something that is very cost effective. It is high value to the patient because it's individualized, and it is one of the only times when the patient is looked at from a functional perspective, and when the focus is not just on disease treatment, but on the person's function outside of the medical office. In order for the prospective surveillance model to be successful and sustainable, the patient has to have access to specially trained rehabilitation clinicians close to home. So there needs to be a training of clinicians so there are more of us out there. And there needs to be ongoing interprofessional education and referral guides throughout the entire cancer center. We can leverage electronic health record systems to help with the prospective surveillance model. We can use electronic health record systems to disseminate patient-reported outcomes on function and to provide decision-making tools and trees, and to automate referrals to prehab and rehab. So I'd like to present a case of how the prospective surveillance model can be implemented. Amy is a 43-year-old female. She's been diagnosed with right breast cancer. Specifically, it's invasive ductal carcinoma and was staged at 1B. The plan for treatment is a bilateral mastectomy with lymph node dissection on that right side and reconstruction via implants, followed by radiation therapy after surgery and implants. So Amy comes to a prehab PT appointment, and this occurs about a month before her mastectomy surgery is planned. In the evaluation, about 30 minutes is spent on medical screening, and she has no physical or psychologic comorbidities. Her BMI is 19. There's also screening of health and lifestyle. She's a non-smoker. She works full-time as a nurse. However, she's on a medical leave of absence currently. Her exercise habits are light walking, 15 to 30 minutes, 5 times per week. And this does not meet the ACSM guidelines because light walking is considered low intensity, not moderate intensity. Her baseline function is good. She has no pre-existing shoulder or neck pain or dysfunction or injuries. And I measured her arm size using tape measurement, girth measurements, and came up with a 7% limb volume difference between her arms. Now, this is relatively significant difference between the arms, but the right arm, the side of the breast cancer surgery or the breast cancer and the upcoming surgery, is also her dominant arm. So she has greater muscle mass and bone mass on that side to explain the difference at baseline. And this is her baseline. So this is the volume and the volume difference that we will be comparing to over time. I used the quick dash to quantify her baseline upper quarter function, and she had no dysfunction or disability reported on that. Also in that prehab appointment, I spent about 20 minutes on education. She was very concerned about her risk for lymphedema, so I thoroughly explained lymphatic anatomy and function. I thoroughly broke down her individualized risk, and I discussed risk reduction practices and treatment options should lymphedema develop. Her risk is dependent largely on how many lymph nodes are removed with her axillary lymph node dissection, as well as whether she goes forward with radiation therapy or not. She ended up having 9 lymph nodes removed, and she had radiation therapy, so she had a moderate risk of developing breast cancer-related arm lymphedema. Education also included discussion about what rehab after surgery looks like. I reviewed the surgeon's post-op movement precautions, and I gave her scapular range of motion and grip strength exercises for early mobilization post-operatively, and I discussed how to resume aerobic exercise post-operatively. Finally, education included what the role of rehab is throughout the continuum of cancer care, and she was very appreciative of that and very agreeable to continue with surveillance post-operatively. Finally, in that prehab appointment, we've done a lot already, but I spent 10 minutes discussing exercise. I discussed pre-surgery exercise prescription and demonstrated as needed how to increase the intensity of her existing aerobic exercise, and I provided recommendations to initiate strength training for that month preoperatively to maximize upper quarter function. She was agreeable. Amy came back about a month post-mastectomy for her PT reevaluation. She had new impairments. She had moderately decreased upper quarter strength, pretty much throughout shoulder flexion and extension and abduction, internal and external rotation. She had mildly decreased shoulder range of motion, in particular of shoulder flexion and abduction. And with overhead reaching into flexion or abduction, she had some pain rated a 4 out of 10 located at her chest wall scars. Those were healing well without signs of infection, by the way. She also had some restriction to her median nerve mobility, and she had some transient post-op edema lingering in the chest wall and the axilla. I measured her arms again, and there was a 6% limb volume difference, or there was a 1% reduction in the size of her right upper extremity. That's the side that the lymph nodes were removed from, so that's the side that I'm focusing on. And that 1% reduction in size is likely due to muscle atrophy in the month post-operatively. So it's not indicative of lymphedema, and in fact, it's showing the opposite, that her arm is smaller. She has a 34% disability on the quick dash questionnaire at this 1 month post-op appointment. So she underwent skilled PT over the course of 3 visits. Those 3 treatment visits included manual scar mobilization on her chest wall and axilla, supervised progressive stretching program with implementation for home exercise twice a day, a supervised progressive resistance exercise program, and I guided her in resuming her aerobic exercise post-operatively in an unsupervised way. There was a lot of education provided in these appointments. She was really, really concerned about her lymphedema risk, so we did screening and exercise progression. I'm good, but you're not. It's fine here. So after 4 visits, oh yeah. Over the course of 6 weeks, she underwent 3 treatment visits plus that evaluation, so 4 total visits. We normalized her shoulder range of motion, normalized her median nerve neurodynamics, and improved her upper quarter function to reduce her quick dash disability score to 27% from 34%. But she did have ongoing strength deficits, and I think that's why her quick dash was not back down to 0 where her baseline was. She had no lymphedema in this postoperative period. So then she underwent a second surgery. This was her reconstruction surgery. It happened 4 weeks after it happened 6 weeks after her mastectomy. I'm sorry, it happened 10 weeks after her mastectomy, 6 weeks after PT started. And she returned to PT 4 weeks after this second surgery. So now we're at 14 weeks postoperatively from her initial axillary lymph node dissection. With this PT reevaluation, she did still have impairments to her upper quarter strength, particularly shoulder girdle muscles. She had mild impairment of shoulder range of motion into abduction mostly, and mild pain of her chest scars. Her quick dash disability score increased slightly postoperatively after this reconstruction. So again, she underwent some skilled interventions with manual scar mobilization, progressive resistance exercise, but continued with stretching and aerobic exercise unsupervised. And we continued to educate about lymphedema screening and risk reduction. She had 3 visits over 3 weeks after this second surgery, in which her shoulder range of motion normalized. She had some ongoing strength deficits still at this point and no lymphedema. We would have kept going with a progressive resistance exercise program, and we did. However, she started radiation treatment. And so at 17 weeks postoperatively, she started radiation treatment, and that was 25 sessions of radiation, so 5 sessions per week for 5 weeks. She came for 3 PT visits during this time, kind of as surveillance or maintenance therapy, where we continued her self-stretching program, and I guided her in modifying the dosage of her strengthening and aerobic exercise at home to address the new fatigue symptoms that were developing during radiation treatment. And then she returned a week after radiation with some breast edema and pain related to that acute radiation dermatitis and persisting mild strength deficits of her upper quarter. We only spent 1 visit together post-radiation because I felt it was appropriate to transition her to unsupervised stretching, strengthening, and aerobic exercise is what it should say. She was independent and safe in all of these things. And while there were ongoing strength deficits, she felt that she could continue on her own. We again, post-radiation, screened for lymphedema of the arm, and there was none. And so at discharge from skilled rehabilitation, her quick dash score had improved to a 7% disability from where it was at 34% disability postoperatively. In summary, Amy received 11 physical therapy appointments over 23 weeks. So one of those appointments was preoperatively, but the other 10 were postoperatively over the course of essentially 19 weeks of cancer treatment. Why I like to outline that and show it as a schematic is the fact that the cancer treatment journey is very long. 23 weeks is almost half a year, almost 6 months, that she underwent a lot of medical treatment and a lot of physical challenges and change. And in 6 months, we only used 11 physical therapy visits to manage her symptoms that were nonlinear in nature. She had range of motion deficits, they improved, they worsened again after the second surgery, they improved again. Strength improvement was not linear and had many plateaus due to second surgery and due to radiation, but she had the foundation of knowledge on how to adjust her dosage of resistance training because of her time with physical therapy. And over those 6 months, we did a lot of lymphedema surveillance. She remained stage 0 or preclinical with no signs of arm lymphedema during that 23-week span. And she did follow up again at 9, 12, 18, and 24 months postoperatively for surveillance appointments. Those appointments were only 15 to 30 minutes in length, and they solely encompassed an arm measurements and a quick interview of symptoms and function. So in summary, the prospective surveillance model is a very proactive model of care to address concerns related to physical function as they happen during the cancer treatment journey. The prospective surveillance model prevents and reduces chronic physical impairments. The prospective surveillance model is efficient and reduces the total number of therapy visits long-term for cancer survivors. Ultimately, it improves the quality of life of a breast cancer survivor, and it improves their function both during their cancer treatment journey and after. So patients really say that they feel supported by this model and that prehabilitation visit is valuable, even if they have a lot of other appointments at that time. With that, I will take any questions.
So if you have any questions, please feel free to unmute yourself and speak, or you can type into the chat. People are coming up with their
Hi,
questions.
Melinda.
Hello.
Hi, Melinda. Great job.
Thanks, Pam.
This is Lauren Gargus.
Oh, sorry. Hi, Lauren.
Hello. I really love the idea of prehab, and I think it's the way medicine should be going, and that we're thinking kind of like proactively and preventatively versus reactively. One question with that first visit that you had, I loved your case study. How are you billing for this from a musculoskeletal standpoint? Since there are no impairments like detected at that point, what codes are you using?
That's a good question, and it is a large topic among our specialty. It has changed over time as my understanding has changed over time of billing practices. I think previously and with this patient, I probably used an quote unquote at risk for lymphedema code or their breast cancer codes, but those are not physical therapy codes. So because she had no baseline impairments, I think that I might use some sort of code to reflect the exercise needs and exercise training moving forward. And in this specialty for pre-op, prehab appointments, oftentimes the models nationally do not bill for those appointments. And then they bill post-operatively for those appointments. So it's an evolving answer.
Yeah, thank you. That makes sense. We run into kind of similar things with prehab for men with prostate cancer,
Yeah.
as you know. One other question I wondered too, is there a way as a department that we can support our lymphedema team in the fact that this is not well known by like medical providers and or patients?
That's a great question. I appreciate it. Ultimately, presentations like these hopefully can be accessible by all providers, not just the rehab department. Ultimately, I have the ears eventually of surgeons, nurse navigators, and other stakeholders in cancer centers. Oftentimes the patient's feedback speaks the loudest. And so I also aim to target the community with this education so that they can advocate for themselves at the same time that we are advocating for them. So there are lots of cancer support groups out there. There's lots of social media avenues to get direct to the consumer who is the patient, and those can be utilized too. Thanks, Lauren.
Thank you.
Hey, Melissa, this is Bonnie Fass. I was just wanting to know about with one of the case scenarios you're talking about, the patient receiving implants and then having subsequent radiation. It's been my experience in the past that they did like some type of soft tissue expander kind of as babysitters while the patient was undergoing radiation, because sometimes there's a lot of soft tissue changes and that can disrupt the final outcome of what the implant's position is in the skin? Have you found that? Do they do radiation after implants, or are they doing radiation before the final implants there?
Great question. Both are options. And that is the decision, I think, of the surgeon and the patient, which direction that they're going to go, because there are pros and cons to either implants before radiation or radiation before implants.
Okay, great. That makes sense.
I can elaborate on those pros and cons, but it wasn't really the scope of this topic. So we can talk offline too.
Sure thing.
Hey, Melinda, it's Angela. I apologize if I'm a little fuzzy. I'm in the car. But in the case that, we come across these patients inadvertently through ortho because they might get referred for some of those shoulder impairments that you were talking about. I know me and you have already talked about it individually, but what are some of the lymphedema screening that some of these other like ortho-based therapists should be aware of if you see this kind of patient population because of that?
Great question. Thank you for asking. So I'm going to flip back to the slide on screening here. This symptom screener is a really nice one to look at, and providers and patients can easily use it. Here from this company, they've published it open access. But ultimately, if a patient is experiencing feelings of pressure in their arm, heaviness, tingling sensations, their watch is fitting slightly differently, their sleeve of their scrub shirt is fitting slightly differently, fullness sensations, as small as they are often the precursor symptoms before we visibly see swelling. And that can be challenging because a patient may be experiencing shoulder dysfunction that's contributing to heaviness, tightness, pressure sensations. And so there's a lot of overlap. A patient may have median nerve restriction, so they may be having some peripheral tingling and changes in sensation, but lymphedema can also cause those same symptoms. So when in doubt, assume that those symptoms might be lymphedema and refer to another provider. Volumetrics or girth measurements can be done by any provider, and sometimes we even teach patients how to do it themselves. Inter-rater reliability is fair with tape measurements, and intra-rater reliability is good if there are standardized landmarks that you're measuring from. So if we're measuring the circumference of a forearm, whether or not the tape measure is an inch or two proximal or distal at any given point can really change that circumference. So we have kind of a baseline landmark of taking circumferences from X distance from either the wrist or from the tip of the middle finger, so that we have a 0 point for the length and the location of those circumferential measurements. So those can be done by any provider if they decide to take one at the distal wrist crease and then every 5 or 10 centimeters proximal to that.
Perfect, thank you.
A lot of electronic health record systems, such as Epic, have flow sheets for entering in girth measurements that can then help calculate volumes. And we utilize something like that in our department, and that's how we can calculate and track our volumes. So that can be used by any provider within our department.
Awesome. So somebody online posted this in the chat. What flyers or educational materials do you have that inpatient therapy staff may be able to provide to oncology patients, either pre or post surgery?
Fantastic question. Thank you. The National Lymphedema Network has a lot of great publications out there, and they are actually this year working on updating a bunch of them. So that is where I direct most providers to go for their education. And then some of the large manufacturers of compression garments have some really nice educational materials on breast cancer-related lymphedema and cancer-related lymphedema in general. So those are out there too from certain companies.
Thank you. So this next question I have is kind of hypothetical. So your patient that you saw for 11 visits over 23 months or over
23 weeks.
23 weeks. I know you did do the surveillance, so in theory prevented additional visits.
So another like 6.
But how many visits do you think would have been if it was unchecked and she came in for course of care for that specific patient?
If she had come in after radiation treatment, which oftentimes is when the shoulder dysfunction really comes to head with patients reporting symptoms and providers referring. So let me back up. After radiation treatment, patients are often returning to work, returning to life roles, expecting to be back to normal because their cancer treatments have completed. They are in remission, if you will. So everyone is discharging them and they're ready to feel like normal again. At that point, if their shoulder dysfunction is limiting their ability to put a glass on a shelf overhead, their ability to wash their hair easily and pain-free, or their ability to work, then they're probably telling somebody and somebody's eventually referring them to PT. So this would be about 4 to 6 months post-operatively. They've been experiencing these symptoms on and off for 4 to 6 months before they get to us. So it's chronic shoulder dysfunction at this point. And that individual, if they went to PT, probably would have PT twice a week for how long? 6 weeks or 8 weeks minimum, to improve their mobility, strength, and pain, but likely longer than that. So I think that at best, it would only be 11 or 12 visits for that patient to receive therapy as rehabilitation after radiation therapy. But I would argue that they have gone 4 to 6 months with symptoms that could have been improved a lot sooner. And for our patient was improved a lot sooner.
So at twice a week for 8 weeks, that's 16 visits. So you're probably saving about five visits of patient's time and a lot of improving quality of care for that 6 months.
Yep, that's a good summary.
Cool. Other questions? All right. Well, if you have any further questions that come up, please feel free to reach out directly to Dr. Steimling or to myself, and I will pass that along. Again, make sure that you sign in using the QR code or the sign-in information at the beginning of this presentation and also in the chat, and complete your quiz and your course evaluation. And we are always looking for further suggestions, so that there's also a section on the course evaluation for that. Thank you very much, and see you next month.